Let's talk about what we're going to do in lab on Friday. We are going to be making a switch to your accidental typodont and prep on it whenever possible. So for this exercise, you're going to need to dig out your accidental typodont. You will find the 2 arches and a screwdriver and a plastic kit, like that you would buy off the rack at the store. And but you've got 2 plates that I think were provided to you by Mike Legess, and you need those plates because that's the mechanism that has the that will attach to the magnet in your sim head. So you can't just put those pink plastic arches in there. You have to have those metal plates. So find those things. We're going to be prepping a number 8 ml using the criteria that we used this summer, but we're also going to use this as an opportunity to practice packing cord and prep a class 5 and restore it. So just because of the way the gums are on the accidental typodont, it's a little bit easier to pack cord and kind of get a feeling what it's like. It's definitely different on people, but this is a good first step. So you're going to take a little piece of the number 0 cord. You can use your flat instrument. You can use a perio probe. There is a cord packing instrument that exists, and y'all are going to use that and fixed. But for our purposes, we're just going to use what we have available in your operative kits. You want to start, you can start at either the mesiofacial or the distofacial, and then you're just going to, pack it down in between the gingiva and the quote unquote bone of your typodont around number 8, just from line angle to line angle. You'll prep an ideal class 5. You want it to be about a millimeter above the gum line. We're not trying to simulate a subgingival gingival margin on this. We don't want to tear up the gums on your accidental typodont, but just use this as an opportunity to kind of see what it looks like, see what it feels like, and you're going to just prep that nice ideal class 5 that follows the curvature of the gum line. We're going to restore both the ML and the class 5 using composite. You need to remove your cord before you start doing your finishing and polishing, just so that you don't get it caught up in your burrs. Again, these are the same criteria we used on your last practical, so it should be relatively fresh in your mind. Just an opportunity to practice some indirect vision on your accidental typodont. It's going to be a little bit different. The teeth are a little bit different, and that's okay. But these are the shapes of teeth that you are going to take your boards on. So it's time to start just using this typodont and get as much practice in as you can. Just a reminder to get these a little bit on the bigger side. I know Dr. Stevenson goes all the way to 2 millimeters in his videos when he preps class 3s, but try to keep it just a little bit smaller than that for our conservative ideal. In reality, if there's decay in one of these accidental teeth, you'll be prepping it to max, but we're not going to do that yet. That's something that we'll do again a little bit later in the semester just to practice, and in the spring you'll have a whole slew of carious accidental teeth to practice on. So try to get it to like the height of your 330 burr inciso gingivally, and that'll give you a decent guide of how big we want these to be. Just some notes to remind you about the shape and requirements for these ideal class 5s. Remember, these are a little different. They really just end up being the size of the decay that you have. We want you to keep the depth into the axial around a millimeter at the gingival wall. It can be a little bit deeper at the incisal wall. Remember, these have divergent walls all around, and so you are going to want to put retention grooves in the axiogingival and the axioincisal line angles. You want to make your outline form extend all the way from the distofacial to the mesiofacial line angle. These are not tiny little things. We want you to have that longer hot dog look to it. You want your axial wall to kind of curve just very slightly with the curvature of the tooth, but also needs to be smooth. It's not going to be flat. It's going to have a smooth curve to it. You can bevel on this since we're doing composite. So you can bevel the incisal, the mesial, or the distal cavo surface margins as appropriate. You don't have to bevel if you don't want to, but it's a good thing to practice. Remember, you wouldn't do that if we were doing this with glass ionomer. You can place your cord before prepping, and that can give you better visualization. If I can get away with it, I tend to wait until it's time to restore, just because I don't want to risk yanking up the cord in my burr. It's so easy to do. And so if I can get away with it, if I can see everything I need to see, then I'll pack the cord right before restoring, just to help control fluids and really make sure I've got lots of good room to get that composite in there with a dry field. You want to leave a tail just a little bit sticking out so that you can grab it with your cotton pliers and remove it when you're done. You also need to make sure that you say that you used cord in your progress note. You also need to say that you took the cord out, and you need to make note of any kind of hemostatic agent that you might have soaked the cord in. So today we're just going to do these 2 preparations and restorations. You do need to put the treatment into Axiom and write a progress note for that, but you don't need to take any pictures for this. So these procedures are going to go under your OP2 patient in Axiom. So we're starting fresh. There should not be any treatment on your patient at this time. And we're going to be using fall patient number 2. So remember, I had that little PowerPoint that had a whole slew of patients in there. We're going to be using fall patient number 2. Her name is Mrs. Crown. And that PowerPoint is called Patients for Axiom 2024, and you should be able to find that on Canvas. You are going to record the screenshot in your second portfolio, which I'll have available for y'all. And that's how we're going to keep track of your Axiom work for this exercise. So this is our new patient. We're going to use her for the next few exercises. She's a 65-year-old African-American female, and her chief complaint is that she wants her mouth to be fixed. She has 4 children. She's retired. She lives in Longview, Texas. I included that. This was an actual patient here at the school in our clinic, and it's amazing how far some of our patients will drive to come see us. I had patients that drove hours to come see me. So it's really important that you use their time wisely and really be appreciative of the fact they're coming all this way to see you. So her vitals for today are 136/88, and her heart rate is 80, and her blood glucose is 85. So this is our first patient that has a blood glucose. And the reason that the student took her blood glucose for today's appointment is because she has type 2 diabetes. So here's our x-ray for today's treatment. You can see the lesion on really 8 and 9. We're just going to be treating number 8 today, going all the way through the enamel into the dentin there. So our patient had a heart attack in 2002, a stroke. At the time, it was recent. These were provided for me in 2019, actually. Like, it was 2020. It was during the pandemic. So it's not really recent anymore. And she has a heart murmur. She has hypertension, type 2 diabetes, osteoarthritis. She has high cholesterol. And again, as y'all are taking pharm this semester, you'll be able to start to really match up, if you can't already, match up the drugs with the malady that your patient has. So note that there's an allergy to penicillin, and these are all things that you want to update if there's changes. But what will happen in your EHRs, you'll get alerts when these kinds of things are entered, just to remind you every time you see your patient, so you don't make any mistakes. This is just a copy of the physical status classification for diabetes mellitus that is posted in each group area in the clinic. And so this is updated from time to time. This might not be the most recent one, but this one doesn't tend to change a lot. We get more recommendations from the American Heart Association about things than we really do about diabetes. And so the school has its own rules about what you need to do, whether you need to get a medical evaluation or if you need to wait to hear from a doctor before you do treatment. I think it's interesting. The only comment I ever make about this every year is that, a blood glucose lower than 70, it says that you can accept treatment with approval from your faculty, but you really got to worry about hypoglycemia. And so this is one of those deals where I think it's good to, if you have a patient with any kind of diabetes, ask them to bring snacks with them, just in case they end up with a low blood sugar. They can have something to eat so that it can hopefully get that up, and you won't have to send them home and not get their treatment done that day. It was a little different when we had patients in the main building because they could go to the cafeteria and get food. I think some students have kept snacks over on the 4th floor in the clinic building just for this purpose, but it's just a good idea to have your patient come prepared. If they need to eat something, then they'll be prepared to do that. It's always really good too, even if you have one that's in a more normal range, like if your patient's blood sugar is like 100, that sounds really great. But what if they didn't eat breakfast and you're going to have them in the chair for like 3 hours? That's pretty stressful, and that might eat up some of their blood glucose. And so it's just really good to kind of know what status your patient is really in. Even if a number looks good, I had a patient once with a really high, the student came and told me that it was something like 280 or something like that, but the patient hadn't eaten and all they had done is drink a Sprite, and that's not going to last super long compared to a really good meal with some good fats and proteins to support the carbohydrates. So it was tricky, and I kind of made them occasionally check the blood sugar just to see that they didn't crash. So lots to be said about that, but it's important. We see a lot of patients that have diabetes, and so you want to be able to manage them really well.